All right, well, good morning, everyone. Thank you all for joining us for today's training. This training is an awesome collaboration between Georgia Department of Public Health, Office of HIV/AIDS, and Georgia AIDS Education Training Center. So this morning, you will hear from subject matter experts identifying the implications associated with perinatal HIV and discussing best practices to apply techniques and strategies. Note that this training is a major key activity in Georgia's HIV perinatal strategic plan. So just a few ground rules. Please make sure you mute your phone and or laptop. Send all your questions and comments to the chat box, and we will address all of those questions at the end of the training. Again, welcome and thank you all for joining us.
Good morning. This is Marcella Ryan Harris with the Georgia AATC program, and this is just to let you know that the slides and today's recording will be sent out to you all on Wednesday, September 2nd. And additionally, this is available for continuing education credits, and you will receive information on how to obtain your credits after the program. And also, do not forget to complete your evaluations for Georgia AATC and the Georgia Department of Public Health. And those will also be sent to you all and provided in the chat box during today's call. First on the agenda, we will have presentations from Dr. Austin Chan and Dr. Gregory Felzine on HIV/AIDS, pregnancy, and the newborn, followed by a presentation from Rhonda Harris about the HIV perinatal program, One Test, Two Lives, followed by a Q&A session. These are the learning objectives for today's summit. And I will pass it over to Dr. Austin Chan and Dr. Gregory Felzine.
Good morning, everybody, and welcome, and glad everyone's up, and hopefully you've had your coffee this morning as we discuss HIV and pregnancy this morning. Next slide. You've seen the learning objectives. We are going to talk a little bit about where we are currently in Georgia, looking at the Georgia STI, sexually transmitted infection landscape, review the HIV epidemic, and adult and adolescent HIV updates. And then we're really going to get into a little bit of the weeds concerning HIV and pregnancy in caring for both the mother and the newborn, and really look at aspects pre-hospitalization, post-hospitalization for both mother and the newborn. And we're also going to end with Dr. Chan discussing a review on vaccine recommendations for individuals living with HIV. Next slide. Dr. Chan.
All right, thank you, Dr. Felzine. I'll keep mine to a brisk 15, 18 minutes here. So we'll start off with a case. 27-year-old female sent from the OBGYN clinic where she presented because she thought she was pregnant. Pregnancy test was positive, as was her point of care HIV test. Screening tests were negative for other STIs. Some basic labs, HIV viral load was 1 million, CD4 650, genotype pending. She's approximately 9 weeks pregnant. Which of the following drugs should be included in her antiretroviral regimen? So let's take a look here. So we've got TDF, tenofovir disoproxil, and then FTC, emtricitabine. And so we're asking you, what do you think is a third good backbone regimen? Give you about 10 to 15 seconds. And you can put stuff in the chat if you'd like to share. Oh, there we go, David. All right, so David's already heard the presentation. So he goes with D-raltegravir, and that's correct. And just keep in mind, this is going to be the BID dosing. So just to double check, make sure you're getting the right dosing, especially for pregnant women. Next slide. So, unfortunately, there's a lot to unpack on this slide, but a couple takeaways, first is that, Georgia remains one of the places with the highest per capita rates of HIV in the country, consistently number one. But the other thing to note is that even though you see our overall national rank falling, our actual number of cases may not be decreasing. Take a look at gonorrhea, where we've gone from 3rd to 15th, which is great. But unfortunately, our number of cases is pretty much kind of plateaued around 20,000. So it's not really, again, rank is important. I know we're all very competitive. This is America. But the flip side is, that doesn't tell the whole story. The only way that we can truly combat these STIs is with sustained, investment, consistent pressure. We can't just see a rank falling and then pull our funding, from our health departments and assume that the problem is solved. It will flare up again. Next slide. So this is just a sense of, where the epidemic is happening. There's no question that there are a lot of people living with HIV centered in the metropolitan areas, DeKalb, Fulton County. But the reality is that there are also, in here, of course, coastal Savannah, there's a high number of cases as well. But it's also important to note that, a significant percentage of patients who have living with HIV do not necessarily live in these metropolitan counties. They live in rural areas. And oftentimes, what Dr. Felsie and I hear is that, we don't screen for it. We don't have that here. That's not our problem. I think it's important to check. If you don't check, you won't know. And we just encourage, stick to the guidelines, stick to the screening. Our goal here is to prevent perinatal transmission of HIV, which, is a sentinel event, which I think is catastrophic. Next slide. So here, this is just a plug for, the HIV care continuum. Here, Georgia does have a very robust telehealth network. If you're interested in joining the Georgia Echo calls, we do discuss some HIV cases there. In addition to that, we want to help you guys, plug in patients if you have them. There's the Georgia Campus hotline. You can also look at the Georgia Campus website. And again, so we can definitely assist in getting patients plugged into care. Feel free to reach out to myself or Dr. Felsie too. Regardless of insurance status, we can figure something out. Next slide. So this is a brief discussion about HIV testing with respect to Georgia law. Something I didn't know before we started doing presentations together. So generally, it does require notification to perform an HIV test. However, you can get around this by simply adding some opt-out language on the existing medical consent form. So in this way, you don't have to have, the quote unquote opt-out testing. You can just include it as part of your standard testing bundle and just put in your medical waiver, we're going to test for HIV. So you don't have to do any pre-counseling. And this should really decrease barriers to screening. Again, we want everyone to get screened. It's just human nature. If you single out a lab, people are going to start asking questions about it. Oh, hey, I'm going to check you for a bunch of stuff and I'm going to get a CBC. Oh, well, what's the CBC? Why are you checking that? Why did you single that out? So I think this is a nice thing, something to keep in mind. Next slide. And here, this is just a brief discussion of, the post-test counseling that you need to do. This is the idea of pre-test counseling. You don't have to do it. Again, all you have to do is include that in the medical form. I would just make sure you look at what your institution is doing. Grady has this in our opt-out medical form. It was updated a little while ago. So not too much of a burden. Next thing here is the post-test counseling. The provider is required to give medically appropriate counseling regarding the test results when the last confirmatory test has been completed, but this is not particularly burdensome. It can be a very, quick, succinct discussion as long as you provide appropriate linkage to care. That's really going to be the critical piece, and is also a key part of the HIV continuum. Next slide. Last but not least, this is a discussion about sharing medical information with respect to patients who are living with HIV. Dr. Felsie often tells stories of how he would request records from other facilities, and basically they would just be heavily redacted, like classified secret compartment documents. But now, we can share health information with respect to patients living with HIV freely. So, previously, if this was seen as a barrier, this is not a barrier anymore. Next slide. So, initiation of ARVs. The new model is that we do this quickly. We do this as soon as possible. There's some good data around early start. And this is early initiation of ARVs is now the standard of care. In addition to that, it's very effective in preventing secondary transmission. The idea here is treatment as prevention. There are some situations, in which you could maybe have a discussion with the client about how willing they are to commit to therapy. Is there a scenario in which you may postpone therapy, based on like intense clinical or psychosocial factors? I think it's certainly the case. If you're concerned about a specific iris syndrome or, drug toxicity, that makes sense. But in general, I would just contact an ID doc and just have a very frank discussion with patients. I've met very, very, very few people who have said, let's get you started on meds to treat this disease. And they say, I'm not willing or I'm not able to do that. To my opinion, that's a very rare discussion. Next slide. And so again, this is the concept of treatment as prevention. The idea here is that pretty much at any CD4 count, start ARVs, doesn't matter. Obviously if you're dealing with pregnant women, certainly those are a critical population. But again, there's the idea of rapid start is, gaining a lot of traction. And this is the idea that if you're in a situation where you can initiate meds, continue, safely with a good transition of care, it makes people feel better to start meds right away when they get a diagnosis. Now, I know that logistically that's not always possible. Totally, receptive to different, practitioner scenarios. Certainly, we barely have this capability at Grady. But if you can, it's a very, very good. It's been shown that it increases follow-up. It increases rates of adherence to medication. And again, there's no CD4 cutoff. Historically, there's been like this kind of 500 CD4 cutoff, but that's completely out the window. Next slide. And of course, U equals U, quick plug. People who are undetectable or untransmissible, this is the new guidance from IDSA and CDC. And this is proven to be true. If you have an undetectable viral load, even if you have unprotected sex, you have no risk of transmitting the virus to your partner. Next slide. I know it's an alphabet soup of HIV medications. There's the 3-letter abbreviation. There's like the, the trade name, the generic name. But in general, what I would do is I would focus on the recommended regimens based on the DHHS guidelines, and you can always find those at aidsinfo.gov. Next slide. And here, is just another list of all the fixed combinations. So if it didn't confuse you enough before, there's like the multi-drug regimens here, 1 pill once a day. That's kind of the standard of care now. But bottom line is, if a regimen looks weird to you, if it doesn't seem like this is the recommended regimen based on the DHHS guidelines, feel free to give ID a call. We're happy to see the patient. It definitely takes a while to wade through this vocabulary, and it takes a while to kind of build up how to approach it. But again, starting with the first line recommended regimens is always the best way to go. Next slide. So this is the sample chart. This is pretty much the chart you're always going to see when you open DHHS. You have your integrase-based regimens up top, bictegravir, TAF, FTC. Of course, dolutegravir, is very popular. The standard combination pill trade name is Triumec there. It's a bacavir lamivudine. And then, of course, you can always combo dolutegravir with the TAF combo pill, TAF, FTC. And there's some 2-drug regimens as well, dolutegravir plus lamivudine. There's also, the PI. Generally, you're going to see the number 1 PI being darunavir. Of course, in pregnant women, atazanavir, much more popular. And so Dr. Felzin is going to talk about what's recommended in pregnancy with respect to these new drug regimens. Previously, we'd always preferred TDF, tenofovir disoproxil fumarate, over new tenofovir, tenofovir alafenamide. Dr. Felzin can talk about the data around that. And there was also some discussion, about dolutegravir. And so I'll leave that to Dr. Felzin. Don't want to go too far into that area. Next slide. So last but not least, this is looking at HIV transmission or transmitted resistance. In general, in Georgia, the few surveillance studies I have seen generally state that transmitted resistance is definitely lower as compared to other more heavily treatment experienced areas. In general, if you're going to have treatment resistance, it's probably going to be in the non-nucleoside reverse transcriptase inhibitor class. the NNRTIs. This is like rilpivirine, this is efavirenz, K103, which provides resistance to efavirenz, is just, unfortunately, is a very common resistance marker that's transmitted. In general, you should feel very comfortable starting an integrase or a PI in someone who's treatment naive. Next slide. So with this, I will turn it over to Dr. Felzine and let him talk about prenatal care and HIV.
Thank you, Dr. Chan. We'll hear from you in a bit concerning vaccines, so I appreciate setting the stage and showing a little bit of the foundation of where we're at and where we're going with HIV and STD care here in Georgia. So when we really think about preconception counseling, I mean, we have to step back and really think about this. Who should get preconception counseling? And a lot of times I get the answer of women of childbearing capacity. And I'm going to argue that everybody who comes into my clinic gets preconception counseling. I have young men that come in who have male partners, and I ask them about their future. Is this a relationship in which these two individuals are going to get married? Have they thought about children? How does that look? Sometimes they want to foster children. Sometimes I hear stories quite often. They have a friend from high school. That friend is a woman, doesn't want to get married, wants to have a child, wants one of these gentlemen to father that child. So we want to have conversations. We want to make sure we're not transmitting HIV or other STDs. And we want to have those conversations as a group. And if I have to have 6, 7 people in my office, I think that's one of the most important conversations that we can have in thinking about individuals wanting families just like anybody else. So we want to think about reproductive options, and are there things that we want to think about? Of course, if the gentleman is sitting in front of me, and let's say it's a heterosexual couple, and he is living with HIV, we want to make sure that he is on antiretroviral therapy and that he is virally suppressed. As you just learned, undetectable equals untransmittable. I will have occasionally women say, well, even though my partner is undetectable, I still want to go on PrEP, pre-exposure prophylaxis, to go to that next level of protection of not acquiring HIV. And that's a discussion definitely to have and to consider throughout that pregnancy. We want safe sexual practices. If individuals are not trying to become pregnant, to really think about condoms, and not just to hand people a bag of condoms and say, here you go, here's your condoms for the day, but taking them out of the bag, opening the package, showing them how to use the condom. I have several 16-year-olds and 64-year-olds that have never opened the package. They don't know how to use a condom. Make sure it's the right size. One size does not fit all. And I've been in clinics where they just have the regular size because that's the cheapest they buy in bulk. But a lot of individuals are taking them and giving them away or throwing them away because they're not the right size. So we really want to also think about comorbidities. So Dr. Chan touched on this a bit. So as you saw on that last slide, I'm going to use a trade name here. Dovato made it to a preferred regimen, dolutegravir 3TC. But if an individual is co-infected with hepatitis B, we would not want to use that agent because we do not use 3TC or FTC monotherapy for hepatitis B therapy. We really want to use tenofovir, FTC, or 3TC in that instance of having dual therapy. So we really want to think about this process. We also, as Dr. Chan said, this is a sentinel event. I'm going to show you a little bit of data that we unfortunately are continuing to have children born in this state with HIV. Next slide. So the other thing to really consider, and this is a bit of an old slide, it comes out of the OBGYN data, but I still think it's important, and some data that I looked at recently really mirrors this, that if you look on the right-hand side, we're talking about preconception counseling from a healthcare provider occurring on average 18.4% of the time. And you can see the high was Maryland and didn't even reach 20% of the time. So these are the times we really need to have these conversations. And when I train individuals and when individuals are in my clinic, what I really try to promote is, okay, you're seeing somebody today who's always takes their medications, always picks them up from the pharmacy, never misses a dose, is virally suppressed, CD4 count of 900. Oh my gosh, this is going to be a quick and easy visit. I'll be out of there in 5 minutes. No, go in, sit down, take a little bit of a social history, ask them about their relationships. What are they thinking about in the future? I have young patients that come in and we start to have those conversations and come to find out they were accepted to graduate school and they're moving off to New York. And a lot of times there's gaps in services when that happens. So making sure we're making phone calls, setting up appointments, and making sure that those individuals are receiving care and there's no gaps in services. Or if they're planning a family, what does that look like? Inviting their partner in to the clinic next time to have that conversation. Next slide. So the initial assessment can be quite extensive. So it all depends on what you do on a day-by-day basis. If you do not take care of individuals living with HIV, then the minimum really is being able to take a sexual history, and we'd be happy to come back at a future date and give some presentations on sexual history and really approaching this in a non-judgmental way. Having those discussions, doing the tests. If the individual, you do a point of care test and they're HIV positive, knowing where to link them and link them quickly so they can get into care. That might be the minimum that you do, or you might be very interested and say, you know what, I want to take care of individuals living with HIV, or I want to do prevention. How does that look? So we really want to do an extensive evaluation when individuals come in when they're newly diagnosed. And the reason being is we want to make sure that we're safely giving them medications. For example, Dr. Chan had mentioned the single tablet Triumec that has abacavir. Well, we need to do an HLA-B5701 test. If it's negative, we can give abacavir. If it's positive, we need to document in the chart that the client has an allergy to that medication, because up to 8% of the time individuals can have hypersensitivity reactions. And when this drug first came out, I've been caring for individuals living with HIV since 1992. When abacavir came out, we were seeing individuals having multi-organ failure with this medication. There have been 0 cases of hypersensitivity reaction with a negative HLA-B5701 test. Now you have to be specific to your lab, because if your lab's not used to this test, they'll do the 2701 because that's what they're used to, which is for diseases like ankylosing spondylitis. So you have to remind this is 5701 that we're doing. We want to assess for hepatitis, tuberculosis. We want to give vaccines. And you're going to hear a little bit more about that from Dr. Chan, but I will plug quickly here is don't assume that the Ryan White Clinic or the HIV provider is doing it, because they're probably assuming you're doing it, and someone else is assuming the OB is doing it, and then the client never gets vaccinated. And of course, if there's any questions about perinatal care, pregnancy registry, there's information here at the bottom of the slide. Next slide. Before we get in the case, I will mention that if you have not received it, everyone will receive a 4-page overview of this discussion. It's kind of a quick sheet that the Georgia Department of Public Health developed in order to assist folks just as reminders of the medications and the points, highlights of the points that we're going to talk about today. So you have a 32-year-old pregnant woman is being seen at her first prenatal visit. She is healthy and asymptomatic. She has been married for 4 years and is monogamous. She has never been diagnosed with a sexually transmitted infection. Her pap smears have always been normal. She lives in a state that requires syphilis screening at the time of delivery. In addition to the mandatory screening at the time of delivery, which of the following syphilis screening strategies for this patient is most consistent with current CDC recommendations? And again, you can put your answers in the chat box. So no additional screening, seeing that she has no risk, screening at the first prenatal visit, screening only if symptomatic, screening only if risk is identified. We have a quiet bunch this morning. So one of the things, we got lots of bees. Okay, so wonderful. So one of the things that we want to try not to promote is, I hear a lot of folks will say, "Oh, first trimester and third trimester." Now that's not correct, because what happens is a lot of times women come in and they're not getting the screening appropriately. It's when they enter into care. So what the current Georgia law says. Once I accept the care of a pregnant woman, I'm offering her I'm offering syphilis and HIV testing at that point, and minimum 28 days prior before she delivers. And why 28 days? Because if her RPR is positive, it gives us a chance to complete therapy prior to delivery, because we don't want individuals born with congenital syphilis, because there's a 40% chance of poor outcomes, including death. And of course, we want to test more often if there is exposures throughout the pregnancy. Next slide. So here's the law I'm talking about. It was enacted in 2015, signed by Governor Deal at the time, just to try to promote that we do want to do this testing and making sure that the individual is treated appropriately. Next slide. So really to just remind us, I mean, the Georgia is not unique in sexually transmitted disease rates. If we look at the most recent CDC updates, we can see in 2018, there were almost 2.5 million cases. The majority of them were chlamydia, but these are on the rise, and these are the highest numbers we've ever seen in the United States. So we have to keep this in mind that no matter where you practice, you're not immune to STIs. So we really have to be able to take that sexual history, feel comfortable with it, be non-judgmental, and really have an open door conversation with individuals about their sexual health and doing screenings. So in the Ryan White world, we're doing at least annual screenings. Of course, we do more often depending on risk and sexual exposures, but at least annually. And I cannot tell you how many individuals who are, quote, monogamous, who've been married for 20 years. Here's my lovely wife. And all of a sudden they're coming in with rectal gonorrhea, and we're having a different conversation. So we're always happy when we make those diagnoses, getting that individual treated, and then having discussions about safe sex. Next slide. So there have been missed opportunities to prevent congenital syphilis in the state, unfortunately. We see in 2017, there were 23 reported cases of congenital syphilis. Next slide. And then if we move to 2018, next slide. You can see that that's gone up to 31. So we're not going in the right direction. And the number one reason was due to prenatal care, third trimester testing was missed. So making sure that we're just giving standard of care and we're catching these diagnoses, because again, this could be just tragic to an individual going through their pregnancy. They end up with congenital syphilis and with a poor outcome. Next slide. And as you can see here, I just like to mention this slide because a lot of times what we hear from an epidemiological standpoint, where is HIV today, really in general, it's young African-American men who have sex with men, but we forget women are part of that equation. Transgender men and women are part of that equation. And transgender populations have some of the highest rates of HIV infection in the country. So we just can't assume, oh, this individual is married, they appear heterosexual. We can't make those assumptions. Years ago, I had been taking care of a heterosexual couple for years, both with living with HIV, both virally suppressed, both taking their medications. They always show up. And the woman said, I need to see you privately next time. I said, okay. And she came in, she goes, oh, I want to have another baby. I'm getting older. I want to have one more child. And I'm thinking about this, and I'm going, well, I've taken care of you and your husband for years, and I know he's had a vasectomy. Is he going to go and have that reversed? And she goes, no, I have a boyfriend. So if she hadn't approached me, I wouldn't have been asking those questions. But luckily she did, and we were able to have that conversation and making sure that this other individual, what their HIV status was. Fortunately, they were negative. We talked about making sure that they remain negative through this process. Next slide. Also the timing. So we want to make sure that we are screening individuals and having these discussions openly each time individuals come in, because if an individual acquires HIV late in pregnancy, that really increases the chance of mother to child transmission. Next slide. And you can see here 2018 and 2019 data are incomplete. But what you see here in this slide is if we go before 2010, what was very interesting was the majority of mother to child transmissions were occurring in Atlanta metropolitan statistical area. And that was because majority of high risk OB cases were being referred to the Atlanta area. And then as specialists were being brought into the more rural areas, what we were finding were some of the rural hospitals did not have protocols in place, they did not have the medications in the pharmacy. and individuals were not getting the appropriate therapy. The majority of the clients still felt they were stigmatized, discriminated against. They were not informing their OB that they were HIV positive. They sometimes would stop their medications. They would present in labor, and the pharmacy in the hospital would not have IV AZT or liquid medications for baby upon delivery. And really, we started to see a rise of mother-to-child transmissions. Next slide. Next slide. So here's a case, a 38-year-old woman living with HIV, taking tenofovir, emtricitabine, efavirenz with routine labs 1 month ago, CD4 count 905, viral load less than 20. After missing her period, she does a home pregnancy test, which is positive and is subsequently confirmed to be pregnant by her primary care provider, who estimates that she is in her first trimester. She intends to continue the pregnancy. What should be done with her antiretroviral drug regimen? And again, you can put this in the chat. Should we stop antiretrovirals until the second trimester? Stop antiretrovirals until labor? Continue the current regimen? Change the efavirenz to atazanavir, ritonavir, or change tenofovir emtricitabine to zidovudine, lamivudine? So we have one brave soul. There we go, a couple of brave souls.
I'll just say Dr. Felzine tricked me on this one too. It's a tough one.
So again, I'm long in the tooth, and we used to stop antiretrovirals, or if they were not on antiretrovirals, would wait until the second trimester, thinking that, oh my gosh, we're going to do damage to baby because of during organogenesis, during the first 4 to 6 weeks of pregnancy. But that has not been laid out. Of course, I'm going to show you some data saying we want individuals on ARVs as soon as possible. Of course, then we don't want to stop antiretrovirals until labor. We don't need to change the tenofovir emtricitabine because that is standard of care. So really, we have to look at C and D. And what the current guidelines talk about is if we know the history of efavirenz, there for a while, when it first came out, there was concern about cleft palate, neural tube defects, other CNS disorders. That data did not tease out in human studies. That was all animal studies. So the guidelines changed. And what the guidelines currently say for DHHS is, in this instance, the client is on a tripla, and I'll use a trade name here, is to continue the regimen. There's no reason to change it. And in fact, if the client is stable, meaning no adverse events, she's not having the CNS side effects, which 53% of individuals will have, abnormal dreaming, dizziness, those type of things. If they're not having those side effects, haven't had any issues, we don't want to risk making a change for possible side effects. Suddenly you might have an increase in the individual's viral load. So the correct answer here is to continue the current regimen. Next slide. We'll talk a little bit about that. So really, if we talk about prevention of perinatal transmission, all pregnant women with acute chronic HIV should receive or continue ARVs to prevent mother-to-child transmission. And of course, continue if it's safe for mother and baby during the pregnancy. So we really want to think about this. And the guidelines really talk about not twisting mother's arm to force her or make her feel bad if she doesn't take ARVs, but to really have that discussion. So we know the sooner you start, the better. And if we can drive individuals' viral loads to less than 50 throughout that pregnancy, we can almost drop that mother-to-child transmission to zero. And there's some newer data showing that really the rates are zero. And you can see here some of the early UK data I'm going to show you is 0.09%. But if mother decides not to go on antiretroviral therapy, her risk of transmission, a lot of folks will quote 25%, but depending on what data you look at, it's 20 to 30%. Next slide. And what do we want to do? So when mother comes in and she's pregnant, let's say this is a new diagnosis of HIV, or she's not on ARVs. Now, if it's a new diagnosis, a lot of times we can assume wild type virus, meaning there's no mutations. I do take care of individuals that come in and said, oh, I've been on multiple regimens, and we pull out the chart. They point to 6, 7, 8, 9, 10, 11 medications they've been on. But We don't see a lot of resistance with the newer integrase inhibitors. Elvitegravir is not as fit as dolutegravir, so many times that we can still use that medication, sometimes twice a day. But let's say this is a new diagnosis. We're getting the tests. We don't need to wait for that genotype, the resistance test to come back. We can go ahead and start a protease inhibitor or an integrase-based regimen. And I'll tell you what I recommend once we get to that slide. But we also want to have close follow-up. And we don't want to just, here's a regimen, see you back in 3 months. Really have that individual come back in 2 to 4 weeks after starting or changing any regimen. And then what the guidelines will say is then monthly until undetectable, and then every 3 months. I take care of a population that there's a lot of very volatile lives, meaning that they might be sleeping on a couch here for 2 weeks, another couch for 2 weeks. Transportation is inconsistent. There may be abuse in the home, which we're working on. So there's a lot of variables we have to consider. So I like these clients to at least be touched by somebody every month. And I don't mean physically touched. That could be a phone call in the era of COVID. Increasing telemedicine is important, but some type of contact. Are you okay? Are you picking up the medications? Because we'll have clients that will have copays of $10 and they're fine paying that every month, and suddenly it's $50, and instead of calling for assistance for a copay card, let's say, or pharmaceutical assistance programs, they'll just stop their meds, or they'll stretch them out. I'm going to start to take them every other day, every third day, and that's how you build resistance. So we really want to think about this process. Next slide. And really meet clients where they are. So if we look at the current guidelines, and typically the guidelines are updated anywhere from September to December. There were some delays in the guidelines last year. They didn't come out till late December. For 2019, so hopefully we'll get them earlier, and some of that had to do with the dolutegravir data that I'm going to show you. So if you look at preferred regimens, bacavir 3TC can be used, but again, we need an HLA-B 5701. Otherwise, the majority of folks use TDF FTC as their backbone, and then you can use protease inhibitors. I tend to shy away from atazanavir. Safe in pregnancy, works great. The reason I do that is for twofold. One, it causes hyperbilirubinemia, and a lot of times their primary care provider doesn't like that, and they start doing extensive evaluations, and I've had some normal gallbladders thrown into the trash as they were sent to surgery, and it was all due to the atazanavir. The other issue is insurance companies sometimes in the second, definitely third trimester, of increasing the dose of atazanavir from 300 milligrams to 400 milligrams and getting that approved can be challenging. Ritonavir has to be twice a day, so sometimes pill burden is an issue. Raltegravir, if we get into the integrase inhibitors, are twice a day in the population I take care of. Sometimes they come back with their bottles where the TDF-FTC bottle is empty after 30 days and the raltegravir is only half empty. And they're saying, well, I don't understand. I took one pill out of this bottle. I was only supposed to take one pill out of this bottle. So I didn't understand that. So we're kind of left, how about dolutegravir? So we could have 2 pills once a day, and it's a wonderful regimen. So you might be thinking, but there's all these issues with dolutegravir, and I have to argue. Well, let's think about that. So if we think about the efavirenz in the case we just mentioned, efavirenz is an NNRTI, and it was moved down from preferred to alternate, and that has to do with tolerability. So our patient in the last case was tolerating the efavirenz regimen. Therefore, there was no reason to change. It's an alternate, so we have to think about that. One thing I will mention is Biktarvy. There's insufficient data. And Gemvoya, Stribild were moved down. They were in insufficient data. We were expecting them to move up to alternates, but they moved down to not recommended because you cannot use cobicistat in pregnancy. At least it's not recommended because there's viral breakthroughs second and especially third trimesters. If you continue a regimen, woman comes in, she's on Stribild, she's been on it for a long time, or she's on Gemvoya, which would be a safer drug. The guidelines say, okay, if she doesn't want to make a change, make sure that you're checking viral loads monthly. And if there's any bump, either you're adding an agent or you're changing the regimen to make sure you get that viral load undetectable. And if I had clients do well with Gemvoya through pregnancy, I've had patients absolutely say, I'm not changing it. and I'm not going to twist their arm. They're willing to come in or go to the local lab once a month, get their tests done. They remain virally suppressed, and all was well. Next slide. Go back to the previous slide. So you'll know insufficient data on the left-hand side under NRTIs. You notice TAF, the third box down, and that's with the white background. Tenofovir alafenamide, currently insufficient data. I'm going to show you some data where I think that's going to move up rather quickly. Next slide. So here's a case. We have a 19-year-old woman. So keep throwing those answers in. So I appreciate that. It helps with the discussion. Presents to her GYN for routine care. She reports no prior illnesses and has never been tested for HIV. Her labs show pregnancy is positive. Ultrasound shows normal at 10 weeks. CD4 count 490. Viral load 200,000. Pan sensitive on genotype. CBC and Kim 12 are unremarkable. And the OB calls you. So you want to recommend elective C-section regardless of viral load on antiretroviral therapy. Single dose nevirapine at time of delivery for mother and single dose for infant within 2 hours of delivery. Lopinavir, ritonavir, tenofovir, and trocidamine to start immediately. Dolutegravir plus tenofovir, TDF, and emtricitabine immediately. So any thoughts? So only 4 answers on this one. And I will say Dr. Hernandez is up on the current literature. We used to use a lot of Truvada Calitra, which is C. A lot of GI side effects with that. A lot of hyperemesis occurring with that. Very challenging regimen. Do I still prescribe it? Yes. I've had women come in and say, this is my 3rd pregnancy. I've always used this regimen. That's what I want to be on. And actually they'll say Combivir, AZT3TC. We don't use AZT anymore because of the long-term bone marrow effects. And I say, okay, if that's what you're willing to take, you've had no problems, we'll monitor you, we'll put you back on that regimen. No issues. Next slide. So if we look at the dolutegravir story, there was this concern of neural tube defects, and the data was coming out of Botswana, in which there was higher rates, and I'm not going to go through this in detail, of neural tube defects with women who were taking dolutegravir, especially prior to becoming pregnant and during the first trimester. So it suddenly became this black box warning to say, oh my gosh, we can't do this. The guidelines changed. We want to avoid dolutegravir. If someone's on it, we want to make sure we're switching. All of these things came to light, but there's always these discussions, and what came to light was, of course, one of the major factors in Botswana was nutrition, and women were not taking folic acid like they should be, as we all recommend for pregnant women here in the United States. And of course, if you're not taking folic acid, it increases your risk for neural tube defects. So the guidelines changed. I'm going to show you a couple of changes and some data that if you're receiving dolutegravir during the first trimester or trying to conceive, most cases the panel recommends continuation of the medication. The risk of neural tube defects is small, and rapid durable viral load suppression is important to prevent perinatal transmission. So I'm going to give you an update here in a bit of recent changes to the guidelines. Next slide. So a really important study came out this year, the Impact 20110 study came out. Now, I will say that these individuals were started on their ARV regimen between 14 and 28 weeks. And worldwide, the most common medication used in pregnancy is efavirenz. So they use a lot of Atripla worldwide. So they were looking at, well, what about dolutegravir? It's just a better drug all the way around compared to the NNRTIs. How is that going to look? Next slide. And I'm not going to belabor this point. You'll have access to these records. But the bottom line was there was 3 arms. There was the efavirenz arms, which was standard of care in most of the countries in which the study occurred. They used dolutegravir with TDF FTC and dolutegravir with TAF FTC. And you saw TAF has insufficient data. Well, what this showed was 98%, so a greater percentage of individuals who were on dolutegravir, didn't matter if it was TAF or TDF, were virally suppressed at delivery, 98% versus 91%. So that's one thing to look at. But then the dolutegravir TAF had the best pregnancy outcomes. So 24% of mothers on TAF had adverse pregnancy outcome versus 33% on the other regimen. That's low birth weight, preterm labor, stillbirth. So, and there were no neural tube defects. Again, but these medications were started between week 14 and 28. So TAF really was shown to be safe in this population and actually safer than the TDF regimens. Next slide. So we're probably going to see that change. So the most recent update in the guidelines says that dolutegravir is preferred throughout pregnancy and as an alternative for women who are trying to conceive. So we just want to keep that in mind. So if a woman is trying to conceive and you're thinking, maybe I'm going to give dolutegravir, have that discussion to say, okay, there was some data. It didn't really pan out, but the guidelines are saying this is an alternate. You know, maybe we should have you on raltegravir with TDF FTC. But again, the raltegravir has to be twice a day. You can't use the HD formulation, 2 pills once a day. It's not FDA approved in pregnancy. Next slide. So C-section, it's recommended if it's going to happen at 38 weeks, and as an infectious disease HIV specialist, I can make that recommendation. And I will say, you know, this individual, based on her HIV and her care, can have a normal vaginal delivery. Now, the OB might say, well, for other OB factors, a C-section is indicated. Okay, I'm not going to argue with that. What I don't want to see is HIV plus pregnancy equals C-section. And we do still have some providers that believe that. They don't care what the HIV viral load is, and that's not appropriate. So if the viral load's above 1,000, acute HIV infection, mother came into care late, was non-adherent with the regimen, these are regions to go ahead and do C-sections. Again, if it's for HIV, it's 38 weeks. Otherwise, if it's for other reasons, then it's 39 weeks as per current OB guidelines. Next slide. And this just shows, and hit it again, that in where everything goes right, this is not the non-adherent, the person who comes late, high viral. This is the person, let's say, has been virally suppressed for 3 years, now pregnant, remains on her regimen, never misses a dose, remains, this is her first pregnancy, C-section and planned vaginal have the same mother to child transmission. And what we recommend is vaginal, normal vaginal delivery. And this group did a follow-up to this study, took the data out to 2015, and again showed that normal vaginal delivery is preferred for that woman who is virally suppressed and adherent to care. Next slide. And the neonatal management really has also changed in the recent guidelines. So if it's low risk, so that patient we just talked about, everything went right, baby is still going to get 4 weeks of zidovudine, and that's AZT. And some people say, oh, they don't need it, mother did everything right. No, mother needs, baby needs 4 weeks of zidovudine, period. That's what the guidelines are. Now, mother will not get IV AZT at the time of delivery if everything went right, but baby still needs the 4 weeks. Now, the old guidelines, if there was any other factors outside of that where everything went right, there were some 2-drug regimens, which are still buried in the DHHS guidelines. But really what's preferred is if anything in there is a concern, then we want to give presumptive HIV therapy. That's going to be zidovudine 3-TC and nevirapine, or what I use, since raltegravir has been FDA approved, is zidovudine 3-TC and raltegravir. I will say Tivicay, dolutegravir PD, was just FDA approved last month, but for individuals that are aged 4 weeks and older. So we're not going to be using it for the newborn. So I would recommend zidovudine 3-TC raltegravir in this regimen, especially if it's a higher risk. Someone's coming in late in pregnancy, viral load is 500,000, CD4 count's 150. I'm going to give presumptive therapy until we get this figured out. Next slide. And this is just for your reference. These are the doses of these medications. Next slide. And next slide. So if you do newborn screening, if everything went right, what's recommended is, of course, we don't want to do an antibody. And we all know that we'll be testing mother's antibody out to 18 to 24 months. So we don't want to do antibody testing. We want to do nucleic amplification testing at 2 to 3 weeks, 48 weeks, and 4 months to 6 months. Now, many hospitals, no matter what occurred with mother through the process, they'll go ahead and get one at birth. I'm fine with that. I have no issues. I'm not going to argue that. If you've got the finances to do it, great. It's not indicated if everything is going right. But this is a team approach. Everybody has to understand how to care for mother and how to care for baby. And what I'll get is, oh, at birth, your NAT at the hospital was negative. Your 2 to 3 a week NAT is negative, so you can stop the AZT. No, you need to complete the entire course of AZT in that situation, and you need to complete the testing. So to have a positive test to say baby has HIV, you need 2 positive tests. Okay, you can't have an indeterminate and a positive. You can't have 1 positive. You need 2 positive tests. If it's higher risk, then we're going to do more testing, as you see, and most experts, and I also agree, then when you get out to 18 to 24 months, then you're going to do an antibody test at that point. If everything's negative, we're done. If there's any positivity, that individual is being referred to care. Next slide. And we also want to follow that up with trimethoprim sulfamethoxazole. Here's the dose. And the reason why we want to do that is if a baby's going to convert, a lot of times it's in that 4 to 6 weeks after the completion of prophylaxis. We do see that. And PCP, which is pneumocystis jirovecii, pneumocystis carinii is a rat disease. It's not a human disease, but it's still called PCP, pneumocystis, PC, pneumonia P. So we want to make sure there's prophylaxis going on. Next slide. And we also want to make sure there's no interruption in therapies. We see this a lot in rural centers where they'll say, well, why don't you just stop your meds and then follow up with your primary or HIV provider, and they'll tell you what you need to do. That's really bad advice. We don't want that to occur. And that's because, let's say the person is co-infected with hepatitis B. Well, those HIV meds are treating the hepatitis B, and we stop, you can have flares. There's cases of fulminant hepatitis and death in the literature. So we want to make sure that we're continuing on with therapy. Also, if the patient, our case was on a tripla, the efavirenz, if you just stop that, what happens is the FTC3TC is metabolized in 3 to 5 days. Now the patient's virus is only seeing efavirenz because it's lipophilic. And suddenly you start to develop resistance. You get a K103N that Dr. Chan mentioned. You go back on the atripla, now you're on dual therapy. In this instance, is not appropriate. Then you get an M184V, now you're on monotherapy. Then you get a K65R, now you're on no therapy. And now you've blown some classes of medications. So always be in contact with that patient's HIV provider if you're not that person. Next slide. Next slide. The other thing is breastfeeding and pre-mastication of food. Have these discussions. Inquire about it to make sure there's not somebody in the home that's chewing the food for the child if that's the culture they do, making sure that they avoid that. The other thing to make sure in your facility is ask what the nutritionist and the educators are telling the patients, because many of my patients come back from facilities and say they felt stigmatized, they were discriminated against, they felt embarrassed because they went in, the nutritionist went in, oh, you have to breastfeed, it's the best thing you can do, you know, et cetera, et cetera. And we don't support breastfeeding in this country because we have alternative feedings. Now, if you want to quote me the World Health Organization guidelines, fine. That's a different world. Those are in developing countries. They have good data. You know, we may change our guidelines down the road, but right now we're not recommending breastfeeding. And if we don't know the status of mother, have her pump, discard, or freeze until confirmatory testing is done. Next slide. And there's always a hotline. Reach out. Dr. Chan said, reach out to us, reach out to your folks. You can make a phone call that's available at the National Clinical Consultation Center and get really good advice. Next slide. Dr. Chan?
Oops, forgot to unmute myself there. So here we go. 24-year-old female has just sustained a puncture wound of her foot while walking barefoot in her backyard. She has had full primary tetanus immunization in childhood, and her last tetanus shot was 7 years ago. She is not aware of any other vaccinations since childhood other than influenza immunization. She has a 6-month-old child at home. Which one of the following should be given to this patient? Is it A, Tdap, B, immune globulin, C, toxoid and immune globulin, D, toxoid, or E, TD? Any brave souls? Some C, some A. Yeah, Dr. Felzine had fooled me on this one again too. So going through the answers, this is A. So first, from the perspective of, looking at, the whole box, you have that standard box of what kind of wound is it? When was their last tetanus immunization? Did they receive their full series previously? Do you need to give toxoid or not? Or do you need to give immune globulin or not? In this case, she's relatively up to date with the 7 years ago. So, and it is a dirty wound, but you don't need to give the immune globulin. The kicker in this case is that because she has the child, and because we know that there's some waning immunity to pertussis, and because she didn't receive her Tdap in pregnancy, that we would go ahead and do the Tdap. That was kind of the tricky part for me, since I'm adult ID. But again, as Dr. Felzine mentioned, don't assume that the other guy's doing it. In a perfect world, obviously, someone who's pregnant with HIV is going to be having ID care, OB care, all that stuff. But too often, we assume that the other person is taking care of the immunizations, the other practitioner is taking care of X, and then it ends up not getting done. So just something to keep in mind there. All right, next slide. So, this is a chart we're all familiar with, the CDC schedule for vaccinations here. Just a couple quick plugs. I'll say in general, live vaccines are not recommended for pregnant women. Obviously you want to hit your critical groups. With HIV folks, there's a ton of recommended immunizations, including regular tetanus, pneumonia, meningitis, ACWY. These are the ones that are not necessarily recommended in everyday folks, that are for HIV specific folks. The other thing that I'll say is that for HIV, immunogenicity, viral load actually doesn't matter too much. It's more about CD4 count. That's what the data ends up showing. So, if you're in a situation where, you really need to catch someone up on some vaccines, and you haven't, and, they have a positive viral load, but their CD4 is okay, that's all right. You don't need to be worried about the efficacy of the vaccine in that scenario. Next slide. Last but not least, this is a semi-new development. So you have the Heplisav B, the Dynavax. This is actually just a 2-dose regimen for immunization of hepatitis B. Historically, we've used the Energix formulation, which is the 3-shot. But in this case, for adults, you can use the 2 doses for catch-up, and this has been proven to be effective and more convenient, which increases compliance and efficacy. Next slide. So, and that concludes our presentation. Thank you so much for having us today. There's a picture of my wife and my 2 kids. You may have heard them jumping around in the background. Again, please reach out to us, if you want additional trainings. We have tons of resources available, or if you don't want to hear us talk, I just want to get you guys plugged into the Southeast AETC network. You could just go to the website, seaetc.com. We have Webcast Wednesdays where we talk about, specific topics related to HIV every Wednesday. There's a ton of, non-clinician training on there too, case manager, pharmacist, ADAP, there's a lot of training modules present on the website as well. And so just want to get you guys plugged in. If you have any consults or anything like that, please feel free to reach out to Dr. Felzine or myself. And if we don't know the answer, we can direct you to someone within the network, who has that expertise. And Dr. Felzine, you want to talk about yourself in the picture?
That's just me standing at Machu Picchu almost exactly 1 year ago when I was turning 50, standing right there turning 50. Look at that. So I definitely would go. Scenery is fabulous. Culture is fabulous. Fantastic trip. Of course, Peru right now is under lockdown. So wouldn't fly there. You may not get out. But once everything is back in order and we can travel, definitely would put that on your bucket list. And it will now open it up. Next slide, Rhonda.
All right, well, good morning, everyone. I am the HIV Perinatal Coordinator with Georgia Department of Public Health, and I am here to give you all some information about the HIV Perinatal Program. Next slide. So the learning objectives for this presentation, pretty much to get an understanding about Georgia Department of Public Health, HIV/AIDS prenatal and HIV care SOP and how to use it for clinical use, for best practices around mother-to-child transmission. And also I will give you all some examples of our current HIV prevention and HIV care services offered by our Georgia Health Departments. Next. For disclosure, there are no competing interests. Next. All right, so let's talk about the HIV perinatal program. So the mission for this program is very simple. We want to prevent HIV transmission before, during, and after delivery, and at the same time, improving the quality of life for HIV positive pregnant women and postpartum women, including their infants. So for the vision here in Georgia by 2022, we want to have 0 perinatal HIV transmissions. Next. So for the HIV perinatal program, we have 3 major goals. And these goals are very important. And so for the first one, we want to increase collaboration efforts amongst our public health agencies to address mother-to-child transmission of HIV. The reason why this goal is so important is because in order to increase collaboration efforts, you do need to work through silos. Unfortunately, during our, here in public health, especially amongst our public health agencies, we have a lot of silos. So in order to work past those silos, we have to increase our collaboration efforts. Next is to reduce perinatal, I'm sorry, go ahead. So we have to, the next goal is to reduce perinatal transmission of HIV. The reason why we selected reduce and not eliminate is because in order to reach elimination, you have to first reduce your perinatal cases. Once you start reducing your perinatal cases, it'll gradually move into elimination. And the third goal is to increase the number of HIV positive pregnant and postpartum women, including their infants, because we want to make sure they are linked, retained, and re-engaged into HIV care. Next slide. Okay, so let's talk about the epidemic here in Georgia. So in the United States, we have Illinois and New York. Also, countries Cuba and Bermuda have eliminated perinatal HIV transmission. So I know instantly when you think of elimination, you're probably thinking of 0. But according to the World Health Organization, elimination of transmission is defined as a reduction of transmission to such a low level that it no longer constitutes a public health problem. Here in Georgia, according to our HIV surveillance, as of December 2019, between 2010 and 2019, we've had 44 babies perinatally transmitted with HIV during and after pregnancy. Now with that 44, you may say to yourself, wow, that's a pretty large number. Why is it that Georgia's having so many babies born HIV positive? Well, the 44 HIV transmissions occurring to some of the gaps with our limited prenatal care. A lot of women are receiving a late maternal HIV diagnosis, and the lack of the 3rd trimester testing. Here in Georgia, we have a lot of mothers that are being tested in their 1st trimester, but unfortunately, they're not being tested in their 3rd trimester. They're receiving a late, they're not virally suppressed, at the time of delivery, and also the baby is not receiving the neonatal nevirapine. Next. So I wanted to show this chart with you all because it correlates with what I just shared with you all. So if you can pay attention between 2010 to 2014, you will see in the dark blue, that stands for our Atlanta Metropolitan Statistical Area, and in the yellow stands for outside of Atlanta. So between 2010 to 2014, we were seeing more perinatal transmissions occurring in the Atlanta metro area. But starting from 2015 to 2019, we started to see a shift, and we're seeing more transmissions occurring outside of Atlanta. And a lot of these transmissions, unfortunately, are occurring because we do have a lot of limited resources outside of Atlanta, especially amongst our infectious disease providers. And we've had a number of hospitals to close outside of Atlanta that would have provided care for pregnant and postpartum women. Next slide. So with all of that information being shared, the number one question is, how can we reach zero perinatal HIV transmissions here in Georgia? So as a part of the HIV perinatal strategic plan, we have several strategies and key activities that help bridge the gaps of missed opportunities of care. So for the sake of time, I'm only going to focus on collaboration, which is a major key piece within the HIV perinatal strategic plan. Next. So as I mentioned earlier, with Illinois and New York, they have both eliminated perinatal transmission. And the way that they eliminated perinatal transmission, they collaborated heavily with a lot of public health and healthcare agencies on the local and national level. I want to focus on collaboration is because collaboration is what's going to help shift the paradigm here in Georgia, and that is how we're going to able to move the needle to reach zero perinatal transmissions, because collaboration is essential. If you think about it, collaboration bridges the gaps of communication. It addresses a lot of missed opportunities of care. It also enhances outreach education and linkage and retention rates. Next. So at the Department of Public Health, we actually created a SOP, a standard operating procedure, for our Ryan White clinics. We noticed within our Ryan White Part B clinics that there were some issues around communication efforts between our Ryan White provider and referred OBGYN, as well as chart documentation and just overall collaborative efforts. So the reason why I'm sharing this SOP with you all is because you do not have to be affiliated with Ryan White Part B in order to adopt this SOP and use it in your departments or agencies and tweak it to fit the needs of your agency or department. We rolled this SOP out as a pilot last year, and we had a lot of great success with the pilot. So with the SOP, like I said, again, is to strengthen the collaboration between our Ryan White HIV care providers and the referred OBGYN to improve continuity of care for HIV positive pregnant women. So so far we've seen a lot of great success with implementing this SOP. The communication between our providers have drastically increased. The chart documentation is a lot better, and just the overall prenatal care, we've seen great improvement with the SOP. Again, we still have a lot of work to do, but I just wanted to share this SOP with you all. If you see a need in your department or agency around collaboration or chart documentation, communication, linkage to care, please take a look at this SOP. Again, you can tweak it to fit the needs of your department and agency. We have the link down at the bottom, so please take a look at the SOP. I think you will find it very beneficial if you are looking to implement a new protocol in your department. Next. So last, I just wanted to briefly talk about some of the HIV prevention and HIV care services offered by our health departments. A lot of times, people that live here in Georgia or not from Georgia may not really know exactly what services we offer. So in regards to our HIV prevention, we do offer free HIV testing. We do PrEP screening, but the PrEP screening is contingent upon the clinic location and resources. All of our clinics don't offer PrEP screening. So again, it just depends on where exactly you're located. We do offer partner services as well as linkage to care, including perinatal. In regards to our HIV care, we do have services around access to HIV medication. We offer mental health counseling as well as nutritional assessment and counseling. So if you are in the need of just wanting more information, please reach out to our health departments. Again, we have an HIV prevention and an HIV care team. If you are needing assistance around a perinatal case, our health departments are more than happy to assist with any perinatal, any linkage issues that you may have. Next slide. Also, I just wanted to briefly talk about our Georgia campus website. Dr. Chan briefly talked about this earlier. So let's just say you're curious to know which services are offered in your area. Let's just say you may be working with the patient, or you just may be curious yourself and you want to know, are there any PrEP services offered in my area, or mental health, or where can I go to get some dental services? You can use our Georgia campus website. You can go to the resource directory where you see the red arrow. You just type in your zip code or your city, and under that, you'll see categories. You can just click on whichever service that you are wanting more information about. So let's just say you live in Savannah and you want to know more information about PrEP. So you would type in Savannah, you would click on PrEP, and on the next screen, it will give you all of the agencies in Savannah that offer PrEP services. So please utilize this website. Please share it with your other faculty and staff, as well as your clients. It's a very exciting resource that we have. We've seen some great success with utilizing our Georgia campus website. Next. That concludes my presentation about the HIV perinatal program. Here's my contact information. Please reach out to me if you would like more information about implementing the SOP, or if you need assistance, any technical assistance with any perinatal cases, please reach out to me. Like I say, we have HIV prevention and HIV care teams in our health departments, and we will be more than happy to provide any assistance that you may need. Thank you. So right now we will take any questions that you all may have. If you have any questions, just type it in the chat box.
Hearing none. I know we have long pauses when you come to our presentation. It's because of our echo training. But I want to thank everybody for taking the time this morning to have the discussion, and do take us seriously. I know you have individuals there to bounce questions off of where you're currently practicing, but if there are additional questions concerning the health department, we can direct you to the appropriate individual. As Dr. Chan and Rhonda had made comment, we're happy to answer any questions about cases, about logistics, about we can hook you up with our legal department if there's additional questions that you have concerning some of the state laws. So please use us as a resource. So do appreciate that.
We do have one question. What needs as of COVID for prenatal care?
Yeah, I think that's a great question. And unfortunately, Dr. Chan's not on to also add to this. Just keeping in mind that when I'm taking care of my pregnant population is doing all the things, the basic things that we need to have discussions with, making sure that there's social isolation, there's hand washing. If individuals are exposed, I know the CDC just released yesterday updated guidelines stating that only to test individuals who are symptomatic, and there's a lot of pushback associated with those guidelines that were just sent out. So in my population, if folks come in and they're concerned, maybe they had an exposure, I'll go ahead and get them tested for COVID. And I'm going to answer this in a couple of ways. First off, I want to make sure that they're aware of what the possible signs and symptoms of COVID are. The majority of folks, luckily, have mild, and then some move into moderate symptoms. And these individuals should just have symptomatic care. And and should be in isolation for 10 days. And that 10 days starts 24 hours after their fever abates. So you have to keep that in mind. If they have more severe disease, obviously we're talking about individuals who are hospitalized, and they need to be in isolation for 20 days after their fever abates. Now, people will say, well, in the guidelines, it talks about individuals who are immunocompromised, and pregnant women are immunocompromised. But the guidelines for COVID really talk about individuals who are severely compromised. So if my HIV, our client living with HIV has a CD4 count less than 200, they fall into that status. The other aspect of this is there was a lot of debate of, oh, maybe we should be changing therapy. There's the old data with SARS and MERS where the lopinavir ritonavir actually treated some folks and they had good outcomes. There is no data to show that changing ARVs, and in fact, the CDC recommends not changing as long as that individual is not having adverse events and that individual is virally suppressed. So there's no reason to change. And I've had a couple of patients call me, because I do see patients across the state, saying, "Oh, here I am. I had a gentleman actually. I'm on Stribild. I want to change to the Kaletra regimen." I said, "Nah, you really don't. You're gonna have a lot of side effects, and there's no data to support that." So it's really just education, making sure that they're virally suppressed, make sure that CD4 count is high as possible, and making sure we're just doing standard of care, vaccinations, we're doing social isolation, hand washing, masks when they're out and about. All of those things are so important. So we have another question that says, how do you see their mental status? Do you see a shift? Routinely across the board, that is a very complicated question and very individualized. I take care of plenty of women who living with HIV that have tons of support. The family comes every time when they come. This is a happy event. That's one side of the bell curve. I also see the other side of the bell curve where individuals are living in households where they're being physically abused, mentally abused, and the pregnancy really adds to that. There's not, a lot of times I take care of individuals with not a lot of resources. And that's where, when I talk about this and touching their lives every month, getting things set up for them, because a lot of times we do see post-delivery depression. We see a lot of that, and a lot of times it's because we didn't do a good job with case management, in which their living situation isn't good. They're not. They don't have enough food in the house. Their living situation is unstable. So really, an opportunity, if you're touching that individual's life every month, having those discussions. Can we get them into a safe place? And we've been able to successfully do that. And then, of course, we do see folks with more advanced HIV, and unfortunately, we still see what's called HAND. We see HIV encephalopathy, and we also see HIV-associated neurocognitive disorders still, which is unfortunate because individuals are still presenting late in diagnosis. And I've actually had some folks the last couple of years saying, oh my gosh, this is like 10, 15, 20 years ago when individuals are showing up late in their diagnosis. And that's why there's a huge movement to really follow the CDC guidelines. The guidelines say it doesn't matter what your risk is. If you're age 13 to 64, you should have a test. And I would argue, and I sent some comments when they were available, public available to the CDC, that age needs to be removed. Because last year there was an 80-year-old woman had lost her husband, entered the dating pool, and acquired HIV, thinking she was safe because she was 80 years old. This isn't my risk demographics. I don't have to worry about that. And all of a sudden she has HIV. And of course, we do see a lot of mental status, whether pregnancy or not. I have a lot of folks that can't take their medications. Every time they look at the bottle, it triggers that they were raped, that sexual assault. They were in a bad relationship where they trusted somebody and that individual was bisexual and ended up transmitting HIV to them. So there's a lot of factors when you talk mental health, and I would say I spend a large proportion of my day discussing individuals' health. How are they doing? Is it consuming their life? HIV doesn't define you. So what are your goals? How can we move past this? And sometimes it takes a while. I had a young man who thought his life was over. And it took a couple of years of doing some psychotherapy in my office. He didn't want to see a mental health provider. talking him through things. He was never suicidal, homicidal, talking him through things. And suddenly 2 years later, he up and moved to Atlanta, let me know. He had a girlfriend, was doing well. He was engaged with his family, was going back to school. So sometimes it takes time. And having these conversations is so important. So mental health is extremely important, to the point where I do a lot of it, and I'm an associate editor for the Journal of Rural Mental Health. And really, it's an underserved and low workforce capacity. We need more individuals doing mental health evaluations. I know it's a very long answer, but it's something I'm very passionate about.
All right. Do we have any more questions? If we don't have any more questions or comments, we will conclude today's training. Please complete the evaluations that are posted in the chat box. Marcella, did you want to give any quick information about the CEU credits very quickly?
Yes, all of the CEU credit information will be provided to everyone who participated in the training today. It'll all be sent next Wednesday, along with the slides and recording, as well as the resource from Dr. Felzine. And you will have 30 days to claim your CE credits.
Okay, well, thank you all so much for taking your time out this morning to join us on today's call, and we will conclude this training. Thank you.
Thank you, everybody. Have a good weekend.
Bye-bye.